Those that have heard me speak before know that I like to start with the basics. If we think of cancer, it's really lethal when it's metastasized. We still don't have good treatment approaches for metastatically widely disseminated cancer. What we do have right now, still chemotherapy kills rapidly proliferating cells non-discriminately. Targeted therapy, I'll discuss a bit more later on, inhibiting the signaling pathways the tumor cells are addicted to. And then immunotherapy. This slide, I made the slide before immunotherapy became all the rage. Immuno-oncology now is a well-established and really quite successful approach to treating metastatic cancer, which kind of fits in between chemotherapy and targeted therapy in that it actually kills cells rather than inhibiting, stopping them from being tumor cells, but in a targeted way and by the localized delivery of radiation. I want to make the point that we've been treating cancer for a long time without really knowing where the therapeutic agent is going, without having a good understanding of the patient pharmacokinetics and biodistribution. And in this presentation, I'd like to basically highlight the idea that the ability, uniquely so, that we have in nuclear medicine and radiopharmaceutical therapy to actually image the therapeutic agent will have an impact on efficacy and cancer patient outcomes. This is a paper published a while ago looking at success rate of oncologic drugs. Bottom line is here. For oncology, our success rate is pretty dismal. 97% of cancer drugs that actually have made it into humans, these are agents that have gone into phase 1 trials, fail. They don't make it to a commercial product. That suggests that we're not doing well. And I think that radiopharmaceutical therapy is an essential additional component to how we treat cancer patients that could make a big difference. A part of the reason that the failure rate is high is highlighted in this slide. This is a slide, a classic slide showing the hallmarks of cancer paper, really identifying the different pathways that makes a cancer cell or that leads to its transformation. And the idea is that if you can find molecules that interrupt these pathways, then you can basically, by continuously supplying these molecules, you can make cancers, put it in stasis so that the cancer cells no longer behave like cancer cells. They don't proliferate. So this looks pretty complicated, but let's look at PTEN AKT pathway. And you can see from this slide that what looked like a one step away from PTEN to AKT is actually much more complicated. So the point of all this is that targeted therapy has been tremendously successful, but cancer cells have a huge set of pathways by which they can achieve their objective, regardless of where you inhibit the pathway. There's also the idea that, and this is a paper that came out of a group at Cold Spring Harbor back in 2019. Title is Off-Target Toxicity is a Common Mechanism of Action for Cancer Drugs. It's a very polite title. The title really should be The Targeted Therapies Miss the Target. What they found is that when they used more advanced methods for knocking out a target that a therapeutic agent ostensibly relies on to prevent a cell from proliferating, the cells continue to die. So whether or not that target was there for a particular cancer drug did make a difference, which basically means that it is an off-target effect, or that what the developers thought they were targeting was some other thing. So lack of understanding on how the drug is really working is the bottom line. And this has an implication, perhaps not all drugs, but this is a sampling of some of the drugs they looked at. And the point they made is 29 different trials, thousands of patients, perhaps highlights why we're so abysmal in treating a very complicated disease, metastatic cancer. There's also this idea of financial toxicity, and this is actually a real thing. The cost of some of these agents is so high, monthly amount in dollars, that the stress of that makes cancer patients be less likely to respond. And it's not like we're benefiting in terms of improved drugs. So this is the ASCO score highlighting a measure of the efficacy of a cancer therapeutic. And this is the rise in price over this time period. Right. So that's what I just said there. Okay. So let's look at radiopharmaceutical therapy. And so I grew up with antibodies. This is a picture of an antibody. You have a linker, and then you have a chelating molecule here. I've tremendously oversimplified all of this. And then into this chelate cage, we can put different kinds of radionuclides. So we could put an alpha particle emitter or a beta particle emitter. And here are some examples. Radium-223, Xofigo, was the first alpha emitter approved by the FDA. It behaves like calcium, targets proliferating bone matrix, and has early trial led to a 2-month improvement in overall survival. And the sense is that there's some sort of signaling involved since this agent only targets bone metastases. More recent agents, Lutathera targets somatostatin receptors for neuroendocrine cancers. So similar kind of construct. This part of it targets or binds to the somatostatin receptor. And this is where the cage holds on to the radionuclide, in this case, lutetium-177. This is showing the electron leads to the therapeutic effect, but also the gamma ray that allows us to do the imaging, the nuclear medicine imaging. Another more recent example, Pluvicto. This is a prostate cancer PSMA targeting agent. Similar kind of thing, showing internalization, then through the radiation-induced effects, damaging the DNA and killing cells. Kind of an overview of how the treatment works. I showed you some of the agents. There are other FDA-approved agents. MIBG is another one. But the basic idea is that you have a patient with some disseminated disease. The treatment is administered intravenously, distributes throughout the body. So not guided missiles. There's no radar on these constructs. The agent doesn't know where to go. It's not homing into the cancer. What it does is it distributes throughout the body. And then when it encounters a tumor cell, it sticks to it. And then over time, those molecules that haven't encountered something to bind to clear, and then you have effectively over time, you have binding. A couple of blood curves highlighting the pharmacokinetic aspects. So for pretty much all therapeutic agents, you get a blood curve, and that's shown here. You can do the same with radiopharmaceutical therapy. But what radiopharmaceutical therapy also does is you can measure the activity concentration over time and get a time activity curve for normal tissue and also for a tumor. And this is here I'm showing kind of an ideal scenario where the normal tissue curve clears with the blood, the tumor persists, and over time you have a longer residency or area under the curve for tumor compared to the normal tissue. And what this requires is to get these points, you have to do imaging, and I'm showing imaging at 3 time points in this example. Focusing on alpha emitters, the main thing here is that alphas are helium nuclei. 2 to 3 tracks through the cell nucleus have the potential of killing a cell. Beta particles are electrons. You need thousands to tens of thousands of tracks through the nucleus to kill a cell. Here, the DNA damage is double strand break, massive damage, largely irreparable. Here, there is the possibility of repairing the DNA damage, and crossfire is required because you need so many tracks through a cell. Just an image. These are bubble chamber images showing visually what an alpha track looks like and what electron tracks look like in the cloud chamber. This is a cartoon by Dave Scheinberg from a while ago, showing again in the context of tumor cells and normal tissues that alphas have a short 50 to 8 micron range. They deposit massive amounts of energy. Betas have a 1 to 10 millimeter range, much lower energy compared to alphas. And this distinction suggests that you can potentially target the tumor cells, but also irradiate normal tissue with beta particles. Another image highlighting the distinction between alphas and electrons. This is a Monte Carlo simulation, the kind of visualized work from Goodhead from a while ago. Each dot here represents an ionization event, meaning that as the particle has traversed the medium, it's knocked an electron off of whatever molecule it was on. And this is now being shown in the context of a chromatin fiber, where you can see the DNA wrapped around the histone, making up this chromatin thing. So right away, you see that there's a much higher density of ionization events with alpha emitters than there is with beta particle emitters. Not to say that beta emitters don't work. We know they do. Lutathera and Pluvicto show that, and so does radioiodine. But the potential of alphas is really tremendous in terms of what it can do. This is what I showed, diagrams and Monte Carlo simulations. This is looking at the molecular machinery that comes together to repair double-strand break damage for breast cancer cells, external beam radiotherapy, and cells incubated with bismuth-213 for an hour. What you're looking at in yellow here is an element of the repair machinery that comes together to repair DNA double-strand breaks. The striking thing is the difference in pattern. The yellow here is where the cells response to damage. And here it's much more diffuse puncture. In a sense, this kind of represents what an RBE really is. You could imagine that if you tally up the total intensity of yellow, in both these panels, the number would be the same, and you can think of that as absorbed dose. But the pattern of distribution is so different that even though the total amount is the same, the pattern is such that the biological damage arising from alpha emitters is much greater than it would be from external beam or low LET radiation or beta particle radiation. People have tried to develop cell lines that are resistant to alpha emitters and have not succeeded. A lot of these efforts have been tremendously impressive in terms of the biology and so on. But at the end of the day, with alphas, resistance is futile. You can have resistance if the alpha emitter doesn't get to its target. But otherwise, if you radiate a cell with an alpha emitter, the resistance mechanisms, the ones we think of conventionally that apply to chemotherapy or to targeted therapy, don't really operate in the realm of targeted alpha emitter therapy. Just some really famous images. This is from the group at Heidelberg, just showing basically a patient with prostate cancer shaking off the disease, and then a few rounds of an alpha emitter labeled a PSMA agent, really having an incredible impact on the disease. The other thing you'll notice is that the salivary glands get wiped out. The disease goes away, and this in a sense highlights the importance of making sure that when we all move to alpha emitter therapy, we do it correctly. So this has been shown a lot. I just want to show that this isn't a one-off. So this is for data from Alphametics with a different alpha emitter, a different molecule, different disease. So this is lead-212 labeled dotamtate targeting patients with neuroendocrine cancer. Similar kind of story. You see pretty substantial disease. And then after a few rounds, patient disease is pretty much cleared, showing some of the impact of being able to image the agent. This is, I guess now you'd call it radiomics, but basically taking a series of images and generating an image of the slope. And we see again, this is going pretty far back. We see for a bismuth-213 labeled anti-leukemia antibody, first injection, last injection, anterior, posterior view, 3 different patients. The pattern looks very different for patient 2. And looking at these images, the group at Sloan Kettering decided that we could do better, but by first using cyclophosphamide to end up with a pattern more like this, where the agent is rapidly being taken up in spinal and marrow regions, which is where the disease occurs, rather than diffusely when you have a huge tumor burden in the patient. A more recent example, this is recent work with Xofigo, radium-223, 11.8 day half-life, 80 micron range. It's a radium chloride calcium analog, concentrates rapidly proliferating bone. About 1.5 microcurie per kilogram is administered every 4 weeks for 6 cycles. This led to a 2-month improvement in overall survival. So what we've done is had a protocol at Hopkins where we imaged patients 3 time points after the first and last cycle. And this is some of the images showing uptake in the spinal column after the first cycle and then after the last cycle. And the point of this is that you can quantify this information, fit it to an exponential expression, and then come up with things like this that show that between the first and last cycle, at least initially in these 3 patients that we've examined, we have more we're looking at, we see a consistent decrease in uptake, which we don't see for whole body or for other regions as a control. We also don't see it in terms of half-life. The other striking thing is the large variability in what happens between cycle 1 and cycle 6, depending on the patient. So I'm showing this. You'll hear a lot more of it from Eric. I just want to make the point that my sense of all this is no photon left behind. The recon implementation that Rapid has put in place basically accounts for pretty much every photon. So you can have very low activity images, 100 microcurie images, compared to 200 millicurie for some Pluvicto, and still get decent images, as I just showed. Just some more images really confirming that the clearance of radium-223 is through the bowel. And then these are images shown at the last society meeting in Chicago, 2023, obtained from Action 1 trial, RayzeBio, courtesy of RayzeBio. Cycle 1, francium-221 is the surrogate for actinium-225, showing uptake in the tumor, 3 different views. At 4 hours post-infusion, you see some bismuth-213 in the kidney. And so this is really valuable data because it's showing for the first time in humans that you can track the fate of bismuth-213. Now, this had been an open question. The FDA is particularly interested in it. By 23 hours, And on the same 6 kilobecquerel per cc scale, uptake retained in the tumor, but quite a bit less so in the kidney. And we have some thoughts on what this is. We're going to look at it some more. But it could be that the initial kidney uptake is due to circulating activity. And once that's cleared, then you have this is a somatostatin targeting agent labeled with actinium-225. By the time that's cleared, then you have less in circulation and less free bismuth concentrating in the kidneys. So I just want to make the point of what dosimetry can do. This is in the context of hepatocellular carcinoma using these microspheres, yttrium-90 labeled microspheres. I'll just show these slides. This was published in a couple of years ago in Lancet GI. A bunch of studies previous to this basically showed that this treatment modality didn't meet its endpoints. What this group did is they looked at a personalized approach to treating these patients in terms of how much to administer. And they found that if with a standard approach, the overall survival, really the real clinically relevant measure of survival, gave about 11-month survival. By introducing personalized dosimetry, they got more than a twofold increase in survival, which is pretty significant already. But then when they looked at patients whose tumor dose was less than 205 gray versus those where they administered that activity to achieve this 205 gray, they found a threefold improvement in so same agents, same patients. The only difference here in improving survival was the introduction of a dosimetry methodology. And I think this is where radiopharmaceutical therapy has its strength. We can image the agents. We can understand what's going on. We know about radiation. By imaging and doing dosimetry, we can really substantially improve patient outcomes. Acknowledgements, a bunch of people in the lab. Hopkins now has a master's in medical physics. And I got an email a while ago from the DOE asking that we acknowledge the program. So thanks to the DOE for making these radionuclides available. And these are some of the grants that have supported the work at Hopkins. Some have probably now expired. That's it.
Okay, so I wanted to talk today about imaging the alpha emitters, and there are a number of challenges with imaging the alpha emitters, and I'm just going to concentrate on measuring the activity at one time point. George already talked about how you take that and do dosimetry and what the dosimetry can do. So I'm going to purely talk about quantifying the activity distribution inside the patient. There are a number of challenges with imaging alpha emitters. The decay schemes are complicated. They have daughters. The daughters emit photons. The radionuclides, unlike the imaging agents, tend to hit multiple gamma rays and X-ray emissions. There's high energy photons that don't provide much imaging information and complicate the quantification. The emitter activities tend to be small. I don't have a lot of time today, so I want to just point to this. I don't get any money for this book. Our APM had a summer school put out a monograph, number 40, and there's an article in there. There are a number of good articles. It expands on the thing I'm going to talk about today. I'm going to talk about 3 radionuclides that are important in targeted alpha therapy: lead-212, radium-223, and actinium-225. And we just briefly review some of the decay schemes and the things that complicate the imaging. If you look at lead, it doesn't emit an alpha, but it decays to bismuth, which does emit an alpha. Ideally, you'd like to know where the bismuth is when it decays, because it has a relatively long half-life and could redistribute. But if you look at the photons that you can image, these are ones that have abundances greater than 10%. You don't see that there are any from bismuth. So what we have to do is image the lead and then infer from that where the bismuth is. Maybe you think you might want to image the thallium, maybe enough photons to do that. The problem with the thallium is they're very high energy photons, and especially this 2.6 MeV photon goes streaming through the collimators and really complicates the quantification. Radium has a little bit more complicated decay scheme. There are 3 alpha emitters emitted over here. Then there's a relatively long half-life bismuth. So ideally, you'd know where the bismuth 211 is. There aren't as many alphas emitted after that, so maybe it's not as important. If you look at the photons that are emitted, there are 2 sets of energy ranges, these 2 X-rays and this higher energy photon that you can image from radium. You could possibly image the radon and the bismuth. We haven't really tried that, but there's enough photons that you might be able to do that. Actinium has, again, a decay scheme that's a little more complicated. The actinium itself doesn't really have photons. It emits some X-rays, low abundance X-rays that you could potentially image, but probably not on sodium iodide gamma cameras. So we're going to concentrate on figuring out where the francium is. Bismuth is also important. It has a 45-minute half-life, so you'd like to know where it is. And fortunately, photons that let us image that. We can use this 218 kV photon from francium and a 440 kV photon from bismuth to do simultaneous quantitative imaging. If you want to do quantitative imaging, you need to do a couple things. First of all, you need to compensate for the image degrading factors. And that includes attenuation, scatter, and the full collimator detector response. And I'll tell you more about what that means in a minute. You need to consider the contributions of photons from the daughters. And ideally, you'd like to model the distribution of daughters. And I'll show you some data today. George already showed you ability to also image the bismuth when you're imaging the francium. Ideally, if you had photons emitted from the source, the only ones that would, all the photons would escape from the body. They would interact with the patient. They wouldn't scatter or be absorbed. Only the ones that are perpendicular to the crystal would make it through the collimator. And if you did that, you get a nice delta function. The response would be independent of position inside the object. And you could use SPECT to acquire projections at multiple projection views around the object and use filter back projection to reconstruct a quantitative estimate of the 3D activity distribution. As I said, there's degrading factors that make that complicate the process. The first is attenuation. Some of the photons are scattered or absorbed inside the body, and that means that the height of the delta function is reduced. And how much it's reduced depends where you are inside the body. So if you look at what that does to the reconstructed images, if you had a phantom that looked like this with a warm background with two hot spots, and you imaged you image the photons that with an ideal collimator, but you had attenuation in the patient's body, then reconstructed that with filter back projection without attenuation compensation, you'd see that you'd get spatially varying loss of quantitative accuracy. The second factor that degrades the images is scatter. The detectors in nuclear medicine have a finite energy resolution, and that means we can't perfectly use energy to reject scattered photons. The collimators, essentially, unlike X-ray imaging, they don't really change the distribution of scattered photons, the ratio of scattered photons to primaries very much. And so the result is that photons that are scattered once or even twice can make it through the collimator, be detected, and give rise to these long tails in the scatter response, the point response. Another difficulty is that the shape of the scatter response is spatially varying. It depends on where you are inside the object. And it also is a function of energy. And this illustrates the effects on the quantitative reconstruction. This is a simple object, a warm background with some couple of cold spots in it. This models technetium imaging just to illustrate the point. If you were able to only image the unscattered photons, you had a detector that could perfectly reject the scattered photons, and you reconstructed it, you could get a uniform image. There's a little bit of noise in it because this is a simulation was done a long time ago. But if you draw a profile through that, you can see that if you reconstructed the unscattered photons compensated for the attenuation, you could get a very good representation of what the activity distribution was like. On the other hand, if the scattered photons are included in the projections and you reconstruct those with attenuation compensation, but without taking into account the scatter, then you get this spatially varying spurious estimates of the activity due to those scattered photons. And the final image degrading factor that I'll talk about is the collimator detector response. The collimator detector response, I said, ideally, only the photons that are perpendicular to the crystal would be detected. But if you did that, then you detect a very small number of photons, and the images would be very noisy. So you use holes that have a finite width, and that means that some photons can get through at non-perpendicular angles, at oblique angles, and that gives rise to this Gaussian shape in the collimator detector response. In addition, especially when you have high energy photons, you can have photons that either penetrate through the septal and are detected, or scatter off the septal detected, and that septal penetration and scatter gives rise to these long tails on the edge at the ends of the distribution. This is an example of what that looks like in terms of images. This is a simulation of 364 keV photons from I-131 at several different distances from the base of the collimator, with two different collimators, medium energy and a high energy collimator. You can see with the high energy collimator, what essentially happens is that instead of getting a little delta function, a single pixel that lights up, we get a Gaussian shape blob, and the width of that blob increases as you get further from the collimator. So the resolution degrades as a function of distance. If you have higher energy photon than the collimator was designed for, so for this energy general purpose collimator, you can see the septal penetration and scatter artifacts manifested by this star artifact. What does that do to the images? One of the things it does is it results in partial volume effects. If we had a phantom that looked like this, and we did a reconstruction with the blurring that's due to the collimator detector response is spatially varying blurring, then that means we would get an image that looks like the white lines here. And you can see that the activity that should have been inside this hot object is now blurred out in the background, and activity in the background is blurred into this cold object. And those are referred to as spill in and spill out partial volume effects, and they affect and degrade the quantification. So that's one reason we want to compensate for the collimator detector response. The second thing effect is that the sensitivity of the system, the number of counts per unit activity per unit time of imaging is no longer constant. If you look at lutetium-177 imaging with a medium energy collimator, you can see that the sensitivity is pretty constant. So if you measure the sensitivity at one distance, then you can essentially convert from reconstructed counts to activity. On the other hand, for something like I-131, even when you use a high energy general purpose collimator, there's a relatively significant spatial variation in the sensitivity. And so it's important to model that in the reconstruction and compensate that for that. So how do we implement the compensation for these image degrading factors? And the tool that's most commonly used for that and what we use at Rapid is iterative reconstruction. And the idea of iterative reconstruction is we develop a model that lets us model that forward process, model those image degrading factors. Given the activity distribution, if I use that model, I can calculate some computed projections. And those computer projections, ideally, if we had the true activity distribution, those computer projections would be the same as the measured projections. And so what we want to do is we want to compare those computed and measured projections, and we want to see how close they are and then update the activity distribution. But because the measured projections are corrupted by Poisson noise, the quantum noise due to the random nature of the radioactive decay, when you do that comparison, you need to use a statistical cost function to take into account the fact that you expect there to be differences due to noise. And the most common cost function used is the maximum likelihood cost function, and it's usually implemented in the OSEM algorithm in many commercial systems. Once we do that comparison, that basically involves taking a ratio of the measured and the computer projections, and then we want to update the estimate. That update is using a back projection algorithm, and a back projection includes a model of the physics because that's what the mathematics tells you to do. And that updated estimate then becomes our new estimate, and we repeat this iterative process until the estimate of the activity distribution converges on the true estimate. How do we model those image degrading effects? At Rapid, we use, instead of using energy windows, the triple energy window method, we use something called this effective scatter source estimation. Sorry for the extra O there. Method that involves using Monte Carlo simulated scatter kernels that are combined in an algorithm that's derived from the imaging physics to give an estimate of the scatter. And one of the advantages of that is that low energy radionuclides such as alpha-emitters, where you don't have many many detected photons in general, the scatter windows that you'd use in something like TEW will have even a smaller number of photons. And building the scatter using the activity distribution in the reconstruction avoids that difficulty because you're using the actual photons, the activity distribution reconstructing rather than measured scatter data from a measured scattered energy window. We implement the collimator detect response compensation using a rotation-based method. So the idea here is that we need to calculate the projection of this activity distribution that's sampled on this square grid. After the collimator detect response is a function of distance from the collimator, one easy way to implement that is to resample the grid so that it has rows that are parallel to the projection direction. You can then use collimator detect responses, a different collimator detect response for each distance. And we use Monte Carlo simulated collimator detect responses, so they're unique for each radionuclide, energy window, and distance from the collimator. You can involve each row with that two-dimensional collimator detect response, and then sum along the projection direction, taking into account the attenuation, and then that gives you the projection modeling the collimator detect response. The other thing that I mentioned it's important to do is to take into account all the daughter and multiple photons that are emitted by the complicated alpha-emitter energy spectrum. And so we do that using a method called the multiple energy range method. And the idea there, George showed a schematic of that for radium that shows it for lead-212. So we divide modeling the photons into the primary and scatter photons. We model those two separately. We break modeling the primary photons into several different energy ranges, a number of energy ranges. And each of these energy ranges would include all the emitted photons in that energy range, including from any daughters that we're trying to model. And each of those energy ranges, we model the energy-specific attenuation and the energy-specific collimator detector response of photons from that energy range into whatever energy window that we're modeling. In this case, a lead-212, the two lead-212 acquisition energy windows. And so and we do the same thing for scatter. The difference here is that for scatter, we put this ESSE method in between, and the ESSE takes the photons, the primary photons that are emitted in the energy range, and propagates those to the energy window another energy range that we use to model the attenuation in the collimator detector response. By doing all these things, we can model the energy dependence and the fact that there are multiple daughters and multiple photons for each of the daughters. How well does it work? This is an experiment that we did, a phantom experiment with lead-212 using a Siemens camera, medium energy collimator, which I don't really recommend. One of our clients, that was the collimator that they had, so that's what we used. This is a relatively simple phantom. It just has a hot sphere with activity in it. The SPECT acquisition and the reconstruction. I'm sorry, I've been limited some of the details of the experiment just because of time. You can see that you get images that look relatively reasonable. These hot rims are a known effect of the collimator detector response compensation. If you draw profiles through those, this shows the profiles and you get a reasonable estimate of what the activity distribution looks like. These are 3 different combinations. So this is using one of the energy windows from lead-212. This is using the other one by itself. And this is using a combination of them. And this is using a method that doesn't use the energy ranges. So it doesn't model all that energy dependence of the attenuation and scatter and all those kind of things. If you look at how accurate they are quantitatively, from the one energy window, we get an error of about 1.2%. From the other energy window, error underestimate of about 10%. And using both of them together, we get an error of about 4%. So I'm going to move on to radium. In a radium, I'm going to show data. We've done phantom experiments also, but to give you an idea of what is capable in a human, this is a realistic Monte Carlo simulation using an anthropomorphic phantom. And we simulated a Siemens dual head camera, medium energy collimator, and used the ExitCat phantom, which is an anthropomorphic phantom developed by Ben Choi and his students. This shows the activity distribution we used, and this is based on data that we got at the time. We didn't have our own data, so we used stuff that was in the literature. We got activity distributions for these organs at these different time points, and we modeled that in this anthropomorphic phantom. These show sample noisy radium-223 projections at the 4 time points, so you can see the issue with the noise. If you do the reconstruction of that and take a coronal slice, these are 5 different coronal slices, you can see that the reconstructed images are indeed noisy. But what really matters is when you sum up the activity inside organs of interest, how accurate are they? So to evaluate that, we simulated 50 noise realizations, again, modeling that realistic uptake, and did the reconstructions of these simulations, and then computed the means and the coefficient of variations. And you can see the results here. The means, these show the mean errors, plus or minus the standard deviations or plus or minus the coefficient of variation. And you can see that in general, the accuracies are 10 to 15% or better, 10 to 13% or better. I guess I should say the standard deviations are, coefficient of variations are all much lower than substantially lower than the biases. This is then switching quickly to actinium-225, and this shows for actinium. Remember, I said we like to estimate both the francium and the bismuth distributions, and this shows illustrates how we do that. In the reconstruction, we model 2 different activity distributions, so we're reconstructing 2 images at the same time, one of francium and one of bismuth. In the projection operation, where we're modeling the imaging physics, we use projectors that model both the francium into its own energy window, the bismuth into its own energy window, and the crosstalk from the bismuth photons and its daughters into the francium energy window, and the francium photons and its daughters into the bismuth energy window. But once you do that, you get some projection images in those 2 energy windows that include the contributions from all the different photons. You compare those to the measured projections, and that gives you the error images, the ratio images. Those are then back projected, again, using a multiple energy range technique to give update images. The update images are applied to the activity distribution images to get our new activity distribution, and then that iterative process repeats. This shows a phantom experiment evaluating the accuracy of that. We used a relatively high activity of actinium because we wanted to assess the accuracy in this instead of the precision. There's a 6 nanometer sphere in the center of the phantom, acquired on a Siemens scanner with a high energy collimator. We used 2 different energy windows, one for francium and one for bismuth. These are the reconstructed images. They look similar in quality to the lead-212 images I showed. Again, you see this hot rim, which is really an artifact of the collimator detector response and not a real phenomenon. It's not the radionuclides sticking to the plastic or anything like that. It's an artifact of the loss of information that results from the shape of the collimator detector response. If you look at the errors in that, we're able to estimate the francium with an error of 8%, underestimate of 8%, and the bismuth overestimated by 1%. So what is the precision of that? To address that question, We haven't done a detailed simulation like we've done for the radium-223, but what we did do is we took the phantom data and we calculated scale factors for the projections that gave us more realistic activity amounts, total activities inside that sphere, and modeled a 30-minute acquisition. We did that 50 different times, so that gave us 50 sets of projection data that had different noise realizations that we obtained using a Poisson random number generator. We then reconstructed those images and computed coefficient of variations for the activity estimates to give some idea of the precision. This shows results. These show the reconstructed images for those 4 different scale factors that correspond to the 4 different total activities inside the sphere. You can see the images themselves get quite noisy, especially the bismuth images getting quite noisy for this lowest activity. But if you look at the coefficient of variation, you can see that even though the images look noisy, the precisions, at least up to this 0.12 megabecquerel, are quite reasonable. So that may seem a little weird, and you may argue that experiment wasn't that sophisticated. But the reason that we think that those results are reasonable is that we have done, Ben did some simulations many years ago when he was doing his PhD, where he simulated indium-111. And the thing we were looking at there is, could we reduce the SPECT acquisition time from 30 minutes to bed position to something less than that? And so in that case, we did a Monte Carlo simulation similar to what I showed you for radium, where we modeled the uptake of indium-111 Zeppelin. In this case, we looked at the 24-hour image. And we did that for 49 different combinations, not just of the same phantom, but different size phantoms with different activity distributions. And then reconstructed those using a method similar to what I showed. It's a little bit less complicated for indium than it is for an alpha emitter. Then we quantified the activity, calculated the coefficients of variation and the biases. And you can see that there's some increase in bias as you go to shorter and shorter acquisition times, but relatively reasonable. You still have biases less than 10% and coefficients of variation less than 5%, even down to very short acquisition times. Even though the images look very noisy, they are indeed very noisy. The last thing I wanted to quickly talk about is imaging. There are some limits when you come to small objects. These are some simulations we did a number of years ago. Ben did a number of years ago using indium-111. You looking at a couple of different tumor sizes, and you can see that these are small tumors that are smaller than the resolution of a medium energy collimator. And you can see that the errors there are quite large. These are mean squared errors, root mean squared errors, and those errors are quite large. For small objects, the ability to quantify is limited. The reliability is limited. For larger objects, these are tumors that are larger than the activity, than the resolution. You can see that the mean squared are acceptable. So the reliability is reasonable. One of the reasons I wanted to mention that is that we think that the ability to do voxel dosimetry with active alpha emitters is probably a little bit limited right now. These show cumulative dose volume histogram. So this is the dose, what fraction of the dose in the organ, so in this case, the liver, had a dose of less than whatever gray is on the horizontal axis. And this shows what it was actually the true dose was in the phantom. It had a uniform distribution in the liver. This shows what you could measure from an optimized reconstruction using an optimal number of iterations and post-reconstruction filtering. And you can see there's some substantial deviation in both for the liver and the kidneys, what the dose volume histogram looks like. And because things like using radiobiological measures of efficacy and toxicity those radiobiological models are highly nonlinear, that these errors can result in relatively big errors in the dose volume histogram. And that's why we've concentrated on doing organ dosimetry at this time. Conclusions that I think quantitative SPECT reconstruction is feasible. It requires careful attention to modeling the physics. The accuracies are reasonable for organ-sized objects. Whole organ precision seems to be reasonable. However, if you look at tumors or voxels, the reliability of things smaller than the resolution is likely to be poor. And that's just because of some fundamental limitations inside SPECT imaging. And I think it is useful to know that we can provide information, as George pointed out, about the distribution of the daughter radionuclides. And again, I'd like to acknowledge the NIH for supporting this, a bunch of people who did a lot of this work, Bayer for the donation of the radium. So that's it.
Just a little bit about RAPID and the history. We work with commercial clients, including radiopharmaceutical drug developers, academics, institutions, clinical sites, and CROs, all at different stages of the drug development process.